Welcome to our Research to Practice webinar series. I'm Ashley Brooks Russell. I'm Director of the Injury and Violence Prevention Center here at CU Anschutz, and we're very excited to have relatively new, still quite new, right? Faculty on our campus joining us, Dr. Ruschelle Leone. Leone, joining us and presenting today on her research, understanding and preventing alcohol-related sexual violence. We do record these, so this, for anyone registered, this recording will be available. And generally people ask if the slides will be available. It's like one of the first questions in the chat every time. So if you don't mind, we can share those slides. And with that, I can turn it over to you.
Sure. Thanks so much, Ashley. Thank you all for being here. I'm really excited to share a little bit more about my program of research that's on understanding and preventing alcohol-related sexual violence. So I'm going to start off by giving a bit of an overview of the types of topics that I study, and then I'm going to dive deep into two areas of research that I currently have funded studies on. So to start, I just want to acknowledge NIAAA, who's funded this research, and note that I have no conflicts of interest in this presentation. So my work studying intimate partner violence and sexual violence is broadly informed by routine activities theory, which is a theory out of criminology, and it posits that in order for a crime to occur, including violence, there has to be a convergence of three factors. So the first is there has to be a likely offender or perpetrator, a suitable target or potential victim, and a lack of capable guardian or a bystander. And it's the convergence of these three factors, or lack thereof, that really creates an opportunity for violence to occur. And so to study this problem, I use observational methods, laboratory-based paradigms, and intensive longitudinal designs to really understand risk and protective factors for interpersonal violence, particularly intimate partner violence and sexual violence, and then use that work to inform interventions. One area of my program of research focuses on elucidating the risk and protective factors for perpetration. So things like substance use, adherence to traditional masculine norms, or stress that men experience from failing to live up to those norms and how that is a predictor of violence. Prior victimization experiences, particularly with between partners. So I look at things often dyadically, so bringing in both members of a couple into the laboratory and studying both of their behaviors and seeing how each person's attitudes or behaviors might impact violence within the relationship. And then I do some work with consent as well in terms of a risk factor for sexual violence. My work in perpetration has really focused on including racially and gender and sexually diverse samples, including college samples and community individuals as well. And I have a recent grant that I'm happy to chat with anybody about, but I'm not going to present here today, that's looking at the acute effects of alcohol and the way that individuals communicate sexual consent or refusals and how that predicts intimate partner sexual violence. In the past 5 or 6 years, I've also focused on understanding risk factors and outcomes associated with sexual violence victimization, including the role of alcohol, emotion dysregulation, and how we can help survivors better after a sexual assault. So what are some of the barriers to care that survivors of sexual assault have? I've also been working on prevention program development and evaluation, particularly around sexual assault resistance education programs, and I'll present a good chunk of that work here today. And I've done a lot of work on other web-based programs as well, looking at acceptability of programs for women, but also for perpetrators and bystanders. Another large area of my work really focuses on bystander intervention and what are the inhibiting and facilitating factors that lead somebody to intervene when they witness a risky sexual or intimate partner violence risk, and ultimately translating these findings into evidence-based programs. My work on this area has really focused both on individual and contextual level factors. So I've looked a lot at men as bystanders, and part of that is that men report being least likely or less likely to have confidence to intervene and report less bystander behaviors when they do witness risky situations compared to women or gender minority individuals. And I am now doing some work looking at gender differences in bystander intervention, which I'll present here today. But the big take home in this work is that it's not just one factor, but often a combination of situational and contextual factors that impact whether somebody makes the decision to help when they witness a risky sexual situation. And as you may have noticed, one factor that I've consistently looked at across all of these areas is the role of alcohol use, both for potential perpetrators, victims, and bystanders. And I look at alcohol because it is involved in between 50 and 75% of college sexual assaults, and we see similar rates in the community. And we now identify it as a contributing cause of partner violence. So not everybody who drinks will become aggressive. It often interacts with individual factors, but it is a cause of violence. So today I'm going to be sharing my work really on the intersection of alcohol and sexual violence. So I'll start by talking about a study that I'm currently conducting that aims to understand how alcohol intoxication impacts bystander decision-making for sexual violence. And this is one of the first studies that looks not just at men, but women as well, and compares gender differences in terms of how alcohol impacts that decision-making. And then I'll shift gears and talk about some of my work with women that I've recently been doing to develop an integrated alcohol, cannabis, and sexual assault resistance education program. And you may wonder why I'm not doing anything with perpetrators right now. And I just want to note that we need comprehensive programs that focus both on potential perpetrators, potential victims, and bystander intervention. Unfortunately, the programs that we do have to prevent perpetration of sexual violence and intimate partner violence so far haven't been effective and haven't reduced rates of sexual assault on college campuses or in the community yet. And some of them actually have been harmful and increased rates of perpetration. So we certainly need that work to continue, and we need comprehensive programs that focus on all of these potential parties. So sexual violence is a significant public health concern, and when I think about sexual violence here, I'm talking about a range of behaviors ranging from non-consensual sexual contact to completed rape. And although anyone can experience sexual violence, women and gender minorities are disproportionately more likely to be survivors of sexual violence. So I'll mainly be focusing on preventing male to female sexual violence in this presentation today. According to the CDC, over half of women have experienced some form of sexual violence in their lifetime, and a fourth of women have experienced attempted rape, and 1/5 of women have experienced sexual violence during their college years. So we see really high rates of sexual violence during this developmental period, and similar rates for non-college populations around 18 to 24. Recent national data suggests that we've actually seen an increase in rates of sexual violence in the past 30 years, and part of that might be because we're measuring it more comprehensively than we used to. But despite the inception of different training programs, we've yet to see those rates really decrease. We know that sexual violence is associated with a host of long-term mental and physical health outcomes, including things like post-traumatic stress disorder, depression, and alcohol misuse. And rates of re-victimization of sexual violence are also high. So I'm interested in preventing not only first instances of sexual violence, but re-victimization experiences as well. And I also just want to note that there is a huge economic burden of sexual violence, which is another reason it's important to study this. The financial cost of sexual assault is estimated to be $3.1 trillion, of which the government is estimated to pay $1 trillion over the course of survivors' lifetimes. So why study bystanders? Perpetrators are ultimately responsible for sexual violence, and of course we need efforts to stop perpetration, but bystanders can play an important role in helping to prevent sexual violence because they're often present in risky sexual situations or behaviors that lead to sexual violence, so precursors to sexual violence, and they can play an important role in that prevention. As such, bystander training programs are increasingly popular in college campuses, in adolescent age populations, and in the military, as part of comprehensive approaches that also look at perpetrators and victims, or potential victims. However, these programs have shown a stronger increase in changing pro-social bystander attitudes, so increasing people's confidence to intervene or decreasing barriers that they see to intervene, but has yet to result in reductions of actual sexual violence, despite their widespread inception in the 2010s. And they have a stronger impact on attitudes than they do on actually increasing bystander behavior. In some work I've done with colleagues, we found that 23% of survivors of a recent sexual assault said that in their view, there was a bystander present prior to their sexual assaults that they think could have helped to prevent what happened to them. And among those women, they also reported that when a bystander was present and could have helped, they perceived that bystander to be intoxicated 90% of the time. So I think understanding the role of alcohol and bystanders is really important because our programs currently fail to train bystanders how to intervene when intoxicated. So often they provide skills and knowledge about risk factors in the environment, so watching out for potential perpetrator and potential survivor alcohol use and what to do in that situation, but they don't really help bystanders how they can overcome their own intoxication to still recognize risk in the situation and actually intervene when they're intoxicated using skills that will work for them. So the bystander decision-making model is a well-supported theory that suggests that for bystanders to intervene, they have to make a series of decisions where they progress from really noticing a situation in the environment to choosing to act. And at each of these steps, there are barriers that might impact intervention. So the first thing they have to do is notice that there is a risk in the environment. And of course, in a drinking context, they might be distracted or having a conversation and not see what's happening right across the room. If they are able to notice, they have to identify that situation as risky. And here they might struggle to do that, especially if they know the two people that maybe there's some risk going on, but they think they have an existing relationship, for example, and they're not quite sure if consent has happened. Once bystanders are able to identify a risk, they have to take personal responsibility to intervene. So think that they have the power in order to stop what's happening from happening. And here, the diffusion of responsibility is a large barrier. So as more people are present in the situation, the less likely people are to feel that they should personally do something because all of these other people are available to help. If they can get past that barrier, then they have to decide how to help. So are they going to directly go say something to those people in that situation, or are they going to go get a bartender, for example, or a resident assistant and indirectly intervene? And then finally, they have to choose how they're actually going to act or choose to interact. So they might be able to see that this is a problem, to think that they are capable of doing something, to know what to do. But a barrier here is that they might fear evaluation from others. So if they go in and they stop that, are their friends going to make fun of them, or is somebody gonna evaluate them negatively, and is that going to impact the relationship? And that's the final barrier that people have to get past. And so both theory and research suggest that alcohol generally creates additional barriers at each step of this model. So it impacts bystander decision-making, but we've also found that it might actually facilitate intervention at certain steps of the model. So for example, prior research has found that alcohol is generally associated with more difficulty in noticing a situation because folks are more likely to be self-focused when they're intoxicated or interpreting it as warranting intervention, often because there's norms around sex that happen in drinking contexts. Conversely, some qualitative research has found that alcohol intoxication is associated with greater intentions or more bystander behavior. So often people say that when they see something and they're intoxicated, they have liquid courage, and so they're more likely to actually go say something and intervene because alcohol kind of emboldens them. However, there's really little empirical research at this point to really disentangle what about alcohol might make somebody more likely to intervene or not. So I conducted one of the first studies to look at acute alcohol intoxication and bystander intervention, and I did the study with men because, again, they're the least likely to intervene and to report competence compared to men or compared to women and gender minority folks. And so this work has found that when men are sober and they have good intentions to help, they are actually more likely to do so in a laboratory paradigm. So intentions here are predicting behavior when men are sober. However, what we saw is that along that red dotted line, among men who endorsed a high willingness to intervene initially, alcohol intoxication actually decreased their intervention behavior in a laboratory-based setting. So alcohol really impacted men who had good intentions to do something more than those who had lower intentions. And so what I think might be happening here is that for some men who really want to do something to help, when alcohol is involved, they get a little bit maybe stuck in terms of what they can do, and they kind of get caught in their head of how they can effectively intervene. So alcohol might really stall that process, likely due to some of the cognitive impairments that alcohol causes. So they're not actually able to effectively help and execute a plan that maybe they have thought about when they're sober. Alcohol myopia theory is a well-documented and accepted theory in the literature that might help us to understand how alcohol impacts bystander behavior. This theory has been widely used for perpetration of violence when intoxicated, and it suggests that intoxicated individuals are more likely to allocate their attention such that they perceive and process only the most salient and proximal cues in the environment when they're drinking. So in this case, perhaps attention is really internally focused about the social consequences of helping, to the detriment of less salient and distal inhibitory cues. So something like a woman's discomfort in this situation, which ultimately can inhibit sexual violence intervention. Conversely, as I said, alcohol's ability to embolden bystanders might be explained by the inhibitory conflict hypothesis of alcohol myopia theory. And this suggests that when there are both strong instigating and inhibitory cues, alcohol's damaging effects to the inhibitory processes allow the instigating pressures to really take over here. So that might yield to greater helping behavior. So in this case, when there's both cues present, liquid courage might actually take over, and the desire to be a hero and help somebody in that situation might be kind of focused on when somebody is intoxicated, leading to more healthy behavior. However, one major gap in the literature that I think can really help explain these differences we see in alcohol use is that bystander research so far has been limited to the ascending limb of the blood alcohol concentration curve. So when BAC is rising compared to when it's falling. So on the ascending limb of alcohol, so you see that limb here, alcohol tends to your BAC tends to peak and then take a lot longer to decrease. But on the ascending limb, where it's increasing, we see that alcohol generally produces some stimulating and arousing effects, which are associated with positive moods. So think about people being more social and laughing more when they're on the ascending limb, but also memory deficits and attention restrictions. And these are the effects that may activate bystanders to actually go in and have liquid courage and intervene when they're ascending and they have a more positive mood and they're really activated by alcohol. However, the descending limb has more sedating effects, which may ultimately decrease intervention. Alcohol continues to have memory deficits when BAC is descending and restrictions to attention, but it also has sedating and dysphoric effects that may impair one's ability to take responsibility or to effectively decide how they're going to intervene. But it's also associated with some of those diminished effects of subjective intoxication, in addition to recovery from cognitive impairments and attentional biases on the ascending limb. So participants might actually be, or people might be more likely to notice what's going on in the situation because some of those effects are really decreasing. And I think understanding limb differences and where people are on in this curve is important, because sexual violence can occur at any point in a drinking context, and sometimes does occur at the end of the night when people are kind of pairing off at the end of a party, and people have maybe stopped drinking an hour or so ago, and now we're starting to see some of those sedating effects. And understanding and elucidating those differences can help inform our bystander training programs by training people what they can do kind of when they're feeling certain ways based on alcohol intoxication. So to address this gap in the literature, I secured an R21 for NIAAA to look at young adult men and women 21 to 30 who engage in social drinking. And we wanted to determine both biphasic effects of alcohol and bystander intervention, but also the effects of gender, and to see if there are different effects when men and women are drinking. And we're a little over halfway through data collection, so I'm going to share a bit more about the design of this study and then share with you some preliminary findings. So here is our study design. So the goal was to recruit 192 social drinkers, 50% of whom identify as women. So this does include trans women and trans men as well in the study design. Participants come into the laboratory and they complete an eligibility assessment. We assess for criteria to make sure it's safe to administer them alcohol in the laboratory, that they've had that lab-based dosage in the past. And then they do a baseline assessment of measures of prior bystander behavior and bystander attitudes. They're then randomized using a 2-1 randomization to either an alcohol or no alcohol control condition. And if they're assigned alcohol, the target BAC is 0.08, and then they're further assigned to complete the study when they're either ascending or descending on the BAC limb. And we're trying to capture kind of the same periods of the BAC based on limb condition. Once they reach their target BAC or a yoked wait time in the no alcohol control condition, they complete a hypothetical heat of the moment scenario that is showing some sexual assault risk, and this was developed out of prior research done with hypothetical heat of the moment perpetration vignettes, and I'll give you an idea of what these vignettes look like. So participants read through the scenario, which has 3 stopping points, and at each of the 3 stopping points, they are asked to think out loud about what they think and feel about the situation and what they would do in the situation. We also are asking them some quantitative questions as well, kind of during, but also mostly at the end of the study. So in this scenario, the first section doesn't have any risk, it's just kind of setting the context for what's going on here. And in this situation, you're pre-gaming for a party at your house. You're there with a few friends, including your friend Marcus. Marcus is eating pizza and drinking beers, getting ready to leave, and you're getting ready to all leave for a house party soon. On the way to the party, Marcus is saying that he wants to take Kim home that night, and you can't imagine that your friend Kim would go for Marcus. You all get to the party and immediately have a shot of beer, and a shot and a beer. There's a stopping point where, again, they're talking about what they're thinking and feeling, and then there is a lower risk sexual assault situation. So here, you all approach Kim and her friends, and Marcus comments on the women's body and makes sexually suggestive comments. The others around you make eye contact. They seem kind of uncomfortable, shaking their heads at Marcus's comments. And then Kim tries to talk to the group. Instead of talking to Marcus, you kind of notice her body language shifting away from him. When she finishes her beer, Marcus immediately hands her another drink. When Kim says she's going to the bathroom, Marcus tries to block her from leaving, gives her an objectifying gaze, so kind of looks her up and down, and then asks if she needs help. She kind of laughs nervously, walks away, and you notice that he follows her. There's a stopping point where folks are commenting on what they think and what they would do. And then in the final section, it's later on in the night, and Marcus has Kim cornered. She's clearly very drunk. I mean, we show this kind of behaviorally. And her and Marcus are dancing. He's rubbing his hands all over her body, and she tries to tug his hands, but she just laughs. And then they start making out. A bit later in the night, Marcus comes over and tells you that he's getting an Uber to take her back to her place to link up, which is language that we learned from our college students. That means hooking up. So we did pilot these and get feedback on these with the college sample before we use them. So that was new to me. And then Kim stumbles past you and falls. Marcus tries to pick her up. She appears to be searching the room, perhaps for friends, but Marcus is pulling her towards the door. Her eyes are glossy and her face is red, so behavioral signs again of intoxication. And the story ends with Marcus helping her out the door. So as I said, we have verbalizations that ultimately we'll code those for bystander barriers that they're experiencing, but also intervention intentions. And then we are collecting some quantitative data as well. So I have some of that preliminary data to share here today. So we looked at the different barriers to intervention and did interactions between alcohol use, the limb condition, and gender. So what we found is that alcohol impacts sexual assault risk recognition, so really being able to see that there is a risk even in this situation, with the higher scores on the axis indicating greater recognition of sexual assault. So what you'll see here on the left is that there's a significant interaction between limb condition and gender, such that men are actually more likely to recognize sexual assault risk when they are ascending compared to when they are descending. On the right, you see a similar pattern of effects between sober and ascending, such that men are more likely to recognize risk when they are ascending versus when they're sober. So there's no difference between being sober and descending for men. In other words, when men are sober or they're descending, they're actually less likely to recognize sexual assault risk compared to when they are on the ascending limb of the BAC curve. And it might be that men are kind of more primed with some of our education, that when they're drinking, there are these risks, and maybe they should kind of keep an eye out for those situations. What we see for women, which I think is not surprising, is that regardless of alcohol, they're just as likely to notice risk. It doesn't matter if they're sober or they're ascending or descending. I think because women are more likely to experience sexual assaults, we're kind of more on the lookout for those risk signs. So it doesn't really matter here with alcohol. Women are just as likely to recognize the risk of sexual assault in the situation. we see a bit of a different pattern of effects when we look at how alcohol impacts one's personal responsibility to intervene. So for this question, we asked participants to rate who is most responsible for stopping what's happening in this situation. So we said, are you responsible? Marcus, Kim, Marcus's friends, Kim's friends. So the graph here is really showing where they put themselves in terms of the level of responsibility between those 5 people. So a 1 would mean that they're most responsible for intervening, whereas a 2 would mean that somebody else is more responsible for doing something in this situation. So again, what we see here is for women, regardless, they tend to view themselves responsible. It doesn't matter if they're drinking or they're not, or which limb, they think that they're responsible for actually going in and helping. But for men, we're seeing that they are less likely to think that they're responsible if they're on the alcohol ascending limb. So they're more likely to recognize the risk, but more likely to think that they should do something when they're ascending. And again, here, no differences between descending and sober for men. So I think the key takeaway here is that, again, alcohol is impacting men, but not women. And it's really impacting men's ability to detect the risk. So again, more likely to detect the risk when they're ascending. And it's also impacting their feelings, so more likely to recognize risk, but less likely to think that they're responsible for doing something when they're ascending using alcohol compared to sober and descending. And so far, we haven't seen any other differences between the bystander decision-making model and alcohol intoxication and gender, but again, we're not fully done with data collection, so it's possible that these findings may change, but I really think it speaks to the nuance, particularly for men, that we need to do more and figure out what those barriers are for men, and then intervene at the specific points and give them more skills or more knowledge in order to actually help when they recognize these risks. In terms of next steps with this work, so again, we're not quite done finishing data collection. We will eventually code these verbalizations and then be able to make some more conclusions here. But I think in terms of where to go next, one area I've been particularly interested in is really looking at the simultaneous effects of cannabis and alcohol on bystander intervention. So what I've heard from college students is that they're all using cannabis and alcohol together at these party settings, sometimes more cannabis than alcohol, and that likely plays a role in bystander intervention as well. Often students have been reporting that they feel safer using cannabis, and they don't think there's as much of a risk of sexual assault, which is not what the data finds, but because they're using around people they trust more often, they don't think it's a risk, so they're not just on alert as much. But some data I've recently collected from women using an ecological momentary assessment, where we asked women to report on their intentions to intervene in alcohol-related harm and sexual aggression when they were intoxicated in EMA, so either using alcohol and or cannabis. What we've found is that alcohol really decreases intentions to intervene in sexual aggression and alcohol-related harm, so things like noticing your friend stumbling or falling. And that simultaneous use also impacts bystander intervention for both of these things, but we don't see those effects for cannabis. So people are saying they're still just as likely to do something when they are using cannabis and EMA, but not so much for alcohol and simultaneous use. So I think we really need more work around simultaneous use to really identify, are there unique barriers compared to alcohol that are getting folks caught up and impacting their ability to intervene. So that's where I'm hoping to go next with this work. So I'm going to shift gears now and talk more about potential victims and some of the work that I'm doing here. And the goal so far of the work I presented really is on engaging bystanders, and I've done some work to kind of integrate some of the evidence we've received so far into bystander training programs to help individuals still intervene when intoxicated, that I'm happy to chat more about. And primary prevention efforts really do have the ability to reduce rates of sexual assault over time. Of course, change takes time, and that might be why we still haven't seen those rates decrease. But standalone programs have really yet to decrease sexual violence perpetration at this time. So to this end, there's been an increase in efforts that aim to empower women to resist sexual assault. And part of this is because women, unfortunately, are the most motivated to prevent something from happening to them. So they're more motivated to actually take these types of programs, to take them seriously and integrate what they're learning. Of course, as I said, the responsibility of sexual assault needs to be on perpetrators, and those programs have yet to be effective and at times are harmful. So I've been doing some work to integrate alcohol and cannabis content into existing sexual assault risk reduction programs. And one of the programs I've worked with is the Enhanced Assess, Acknowledge, Act Sexual Assault Resistance Education Program. This is a program out of Canada by Dr. Charlene Zen that trains women broadly to do three things. The first is to assess the risk of sexual assault from acquaintances. So women are most likely to be assaulted by somebody they know. So to make that risk real to them and to think about who in their life might actually perpetrate something like this. Then to overcome emotional barriers to acknowledging danger. So often women are friends with somebody who might be starting to perpetrate something from them and they might worry about hurting that person's feelings, for example. So how do we overcome those emotional barriers? And then to effectively engage in physical and verbal resistance strategies. And this program is evidence-based. It's recognized by the CDC as being an evidence program to prevent sexual assault and has shown reductions in sexual assault for up to 24 months post-intervention. So in my opinion, this is one of the best programs that we have out right now. However, the program doesn't currently target heavy drinking or cannabis use, which we know are two known risk factors for sexual assault. So I think a critical next step is to really integrate alcohol and cannabis content, particularly for women who are using alcohol and cannabis at high levels and are at an increased risk of experiencing sexual assault. As I said earlier, we know up to 75% of sexual assault victimization involves alcohol, either by the perpetrator or victim. And so it's certainly important that we include this in our efforts. And both heavy episodic drinking and cannabis use significantly increase the risk of sexual assault, and using these two simultaneously such that their effects overlap increases sexual assault risk above or beyond either substance. What we know for some recent research as well is that sometimes it doesn't even have to be that a woman is using cannabis or alcohol, but just being in an alcohol or cannabis setting increases the risk of sexual assault. So for this next study, I was funded by a Career Development Award from NIAAA to develop an integrated program for alcohol, cannabis, and sexual assault risk education. And this study focuses on women aged 18 to 24, which is who the program is initially designed for. The real-world implementation of this program has recently found that it's effective for women up to the age of 64 years old. So I have three aims with this study. The first is to create new program content, and then look at determine the acceptability and usability of the data, and I'll share some of those findings today, and then finally to test the feasibility and limited efficacy. So to give you a quick overview of the program, so this is a 12-hour in-person program initially, and there's 4 separate modules. So there's an assess module, an acknowledge and act, which really gets at those things I discussed earlier. And then there's also a relationships and sexuality unit, which is basically sex education for women out of our whole lives. And I think this is important because a lot of women don't get sex education. I was previously in Georgia where there was no sex ed. So this was often folks' favorite unit of this program because they got some really cool content. And so for the integrated program, which I'm calling NIAAA Plus, we are integrating in-person content into each of those units. And then we also are adding a web-based module, which we're calling Safe Review for Substance Use Awareness, Facts, and Education for Sexual Assault Resistance at the university. And so this is a web-based unit based on Basics, which is an alcohol intervention program, and Positive Change, which is an integrated alcohol and sexual assault program. So we're adding cannabis content here, and I'll go over this, give you some ideas of what this looks like in a moment. So new content was designed through focus groups and pulling from theory and evidence that is designed to do 3 things. So the first is I'll start by saying that one of the goals with this is to really develop content that aligns with the ethos of NIAAA, which is to empower women to make choices about their own behavior. So we're not here to tell anybody that they should stop drinking or that drinking is going to lead to sexual assault for you, but really for them to consider their own alcohol and cannabis use, decide if they want to make a change or not, and then decide if they want to use in different ways that might be safer. So that's what we're doing here. So we're encouraging women to consider their substance use and use-related experiences and make any changes that they might want to make, and then provide strategies to do that. We're providing strategies to use in situations where a coercive man may be present, while reinforcing that he is entirely responsible for his actions. So a woman is never going to be sexually assaulted when drinking or using cannabis unless there's a coercive man present. So we reiterate that through the program, and I'll show you how in a moment. And then we want to increase confidence and skills to successfully engage in sexual assault resistance when intoxicated. So women often think, well, I can't still You know, I'm not going to physically be able to push somebody away or to punch them when I'm intoxicated. And in fact, they can if they learn the proper strategies to do that when they're sober. So really trying to foster that confidence. So I'm happy to talk more about the in-person content, but I'm going to focus a bit on the web-based content because that is where the crux of the new content really lies here. So this is a 15-minute web-based module that they take in between some of the in-person sessions. Women take the program either over 2 days or 4 weekend nights, and halfway through they get this module that is personalized to them. So we provide psychoeducation on alcohol, cannabis, and sexual assault pretty broadly, and also some specifics here. And as I said, we really discussed that women are not responsible for sexual assault. They won't be sexually assaulted while drinking or using cannabis unless there is somebody there present to do that. So we start this web-based module off by making that really clear, and you can see that on your left. We then provide more information about why women who are using might be more likely to experience sexual assault, and part of this is that potential perpetrators might be targeting them because they know about the impairing effects of alcohol or cannabis. And we make this risk personal to them. So here we know that difficulty in perceiving risk in a situation starts to really decline around a VAC of 0.05 to 0.06, though there's some variation. And we let them know for them how many drinks it would take them to get to that point. So for this woman, based on her weight, it would take her about 2 drinks. We then provide personalized feedback for the risk of sexual assault while using alcohol, cannabis, and simultaneous use based on norms for the campus. So these were norms from my prior institution at Georgia State University. So we collected some norms first and then gave this data back to women within the intervention. So in this example, this woman believed that 7% of students at the university experienced sexual assault while using cannabis. In actuality, our data would suggest that about 21% of women did. So kind of getting them to see the reality that this is still a risk. We also give them normative feedback based on their own cannabis use, alcohol use, and simultaneous use. So the idea here is that people often overestimate how much their peers are using and are using more to keep up. And if we can give them the correct information about what their peers are actually doing, it helps to decrease substance use. So you see that example on the right where this person is using much more cannabis than their peers, and they think their peers are actually using more when they're using less. And then finally, we provide protective behavioral strategies. I'm aware that you might not be able to read that, but basically what we do is we give somebody a situation of a risk situation where a man is pressuring them to use more substance use, and we ask them to practice what could they do here instead of drinking. So what are some of those protective behavioral strategies they could use? So things like using water instead or pretending to take a shot, but really not. One of the things that really came out of a lot of our focus groups is that women wanted more content to be able to cope with stress and anxiety, and that was a major motivator for them using alcohol and cannabis. And so we provide some strategies here of what they can do instead to cope. And these were strategies that were informed by our focus groups initially, and we provide some resources on campus they can use and get them to think about, you know, if they are going to want to make a change, what are those replacement behaviors that they're going to do? So after we developed all of this content, we piloted it to determine the acceptability and usability of the content. We did this with 14 college women who completed the full roughly 1.5-hour intervention now. And in order to be eligible, they had to engage in heavy episodic drinking, cannabis use, simultaneous use, and have intentions to do this again in the future. So we didn't want people that maybe had done this previously but weren't interested in continuing in the future. Excuse me. Women completed baseline and outcome assessments for alcohol use, rate of acceptance, and then they completed measures of acceptability and usability. And we had them do this after each module as well as at the end of the program. So I'm going to share with you the acceptability after each module, and I'll say this is aligned with what we had for the full program. And so we looked at a range of acceptability metrics, like if they liked the content, if they were comfortable, if they thought it was interesting. And you can see overall, so this is a 1 to 10 scale, with 10 being highly acceptable, that women really liked this content. They thought it was interesting. They learned something. We had mostly 9s across the board, some 8s, especially in the first couple units. But women liked the content. And some of our qualitative interviews that we did after the intervention, women said things like, you know, this program was a little bit long, but I can't think of one thing to cut, and every woman should take this program. They thought it was really useful, and then I think what's important is they were likely to recommend it to other women. We also looked at pre-post changes. So immediately after intervention, they did another assessment. And so this is not assessing any behavior, but kind of some changes. One is descriptive use norms. So are they more accurately reporting what their peers are doing on the campus? And we did see significant differences. So they were more accurate in reporting their peers' drinks per week or drinks per occasion, as well as drinking days. We saw some changes in cannabis use norms, particularly around hours high and days using per month. We didn't find any differences around grams, and my hypothesis there is that women really struggle to estimate what a gram is despite pictures, so we're thinking about changing that content for the next iteration of this intervention. And then we saw significant changes in simultaneous use for descriptive norms as well, so that went down significantly. And I think these are really promising because we know that these norms often do predict changes in behavior. We also saw changes in the substance use ladder, so we were trying to assess what is their likelihood to change substance use, and we saw significant changes in simultaneous use. So going from a 0 to 10 scale here, they started at about a 1 and got to a 5, and this is statistically significant, but also clinically significant because people are really moving from pre-contemplation about whether they want to change their use to contemplating about their use. We didn't see those same significant changes, but they were going in the right direction for alcohol and cannabis use. We also asked about their sexual assault resistance when using alcohol and cannabis. So how successful do you think you would be when you were using alcohol or cannabis at resisting? And how confident are you at your ability to do so? And we saw significant increases in both of these metrics. So I think the key takeaways from the study is that women really liked the program. They thought it was really highly acceptable. They thought everybody should take it. They did recommend a couple changes in our focus groups, but that was really around including more cannabis content. So we tried to be conservative in what we included because there's not a ton of evidence on the way in which cannabis impacts sexual assault risk. So we were really relying on what's available, and they wanted more. They wanted to know more about cannabis use, how it might impact them. So we're kind of working through making some of those final changes now for the next iteration of the program. We also had promising preliminary outcomes pre-post. Certainly we need a larger sample to really look at changes across time and see, does this actually decrease sexual assaults at the same extent that it does in the original program? Is it decreasing alcohol and cannabis use? And is it allowing women to be more successful at actually resisting sexual assault while drinking or using? So we'll do that in a limited efficacy trial after we collect some new norms here at CU to integrate into this program, and then we'll test it with college populations here for follow-ups up to 6 months. So I want to end by just saying that, although I study violence research isn't about violence because it really intersects with so many areas of mental and physical health. And we know that violence exposure is a social determinant of health and is associated with a vast number of health outcomes, many of which you see on the screen here. And while I don't have expertise in a lot of these areas on the screen, my program of research, I really hope to integrate that with other areas of public health as well in order to ultimately decrease rates of violence. One of my colleagues likes to say that violence prevention needs to be like fluoride in the water, that if we can really integrate it in all of these other areas like sleep research and interventions and maternal health, that ultimately we can make a difference at decreasing violence. So I'm hoping to meet with other colleagues here at CU that do other work and talk about how we can ultimately prevent violence. Thank you.
Looks like we have probably 10 or 15 minutes for questions. And for those of you online, this is like a webinar, so you're kind of locked out. So if you do have a question, the best way is to probably put it in the chat, because I don't know if it's so easy to unmute. And I can monitor that and read them out. And I guess I'll start with a question, thinking about this EAAA plus or intervention that you worked with. If I understand it, you brought that substance use content to it. Mm-hmm. Are you aware of, or have you thought about kind of the flip, which would be interventions to reduce binge drinking and integrating then the sexual violence content? Mm-hmm. If there, and perhaps interventions to reduce problematic drinking have that unintended, or unstudied consequence of their programs if they're very effective,
Yeah, I certainly have, and I've done a little bit of work with colleagues to do that work. So really starting from alcohol interventions to reduce binge drinking, and then how can we integrate some sexual violence work in that. I think historically colleges are mandated to do training both in alcohol use and violence, and very rarely actually integrate them. And I think it does everybody a disservice to not talk about those things together, because that's where they're happening often in drinking settings. So, I think even if it's not a high dosage, if we can start getting more violence content into those interventions, I think it can make an impact.
Yeah. And thinking about that collegiate setting and age group, are you seeing, I would think there'd be some reasons for optimism in terms of colleges sort of taking more ownership of it. I mean, what are you seeing in terms of the environment for adopting these sorts of?
It's a good question. So it is mandated on college campuses, and I think it's really who the decision makers are on that college campus. So a program like NIAAA is really high resourced. You need to train facilitators, you need somebody that can supervise them, and it goes to a training in Canada or brings trainers to the United States in order to be able to facilitate the program. It's 12 hours, it's just for women. So I think when those people get on, we can get people on board at universities, then it's really effective. I think some universities are unfortunately still checking the box, and they're using really expensive programs that don't have evidence or good evidence behind them, and their online trainings. And I think what we know is dosage matters. The way that content is delivered matters, that it needs to not just be something that's delivered at the start of freshman year, but we need to have content throughout. So I've certainly worked with really good administrators that were, motivated to have content throughout the college years. I've worked with Greek and Greek life as well to do some of that content. So again, I think it needs to be like fluoride in the water everywhere. If we could get content into freshman orientation classes, and we could talk about it in our statistic classes, and violence against women there, violence against sexual and gender minorities, because those rates are high, that it could really make a difference on our campuses. So in short, I think it really depends on who the decision makers are, and if we can get more people advocating, I think it will make a difference.
I have a question.
Sure.
You mentioned bystander training. Is that integrated into what you're doing through this program? And also a secondary question, have you ever explored bystander training in other settings? You mentioned bartenders. So I'm curious if there is any sort of training that would be beneficial to those kind of settings.
Sure. So for your first question, so there is no bystander specific content in NIAAA or in this new iteration I'm doing, but I suspect that it does increase bystander intervention. So it is an outcome measurement that I'm planning to include here because I think there's no way it can't. Initially this was really just for sexual assault, and there was a recent study that came out with this program that found it also decreases intimate partner violence as well, which I think is really important. So I think that the principles that it's using can be really effective for both preventing one's own, but also intervening, because you're becoming more aware of what those risks are and what to do in those situations when they get verbal and physical self-defense training. So they're not only using it for themselves, but for other women, I suspect, as well. So I do think it likely does, but there hasn't been any testing of that yet, and no specific content that really talks about being a bystander. Your second question about bystander intervention in other contexts. So yeah, there's some great programs out there that try to train bar staff. There's a program out of Arizona called Safer Bars that they just did a large efficacy trial on. They got funded during COVID, and that shut them down for a while, but they're analyzing their data now. And so they go in and do training with bar staff for recognizing what some of those risk signs are. I believe they talk about other forms of violence too, like physical violence, not just sexual violence. But I could be mistaken, because there's a program out of Canada that does that as well. And then have shown some promising effects on getting bartenders and different staff at venues to intervene in sexual risk. I think the hard thing with those programs is they're really resource intensive, and the bar owners have to be committed to training their bar staff. So staff have to come in for a 2-day training, they're paying them for that. So that's another thing where I think you really have to have people invested in that topic. But yeah, there's some great work being done on that.
You mentioned how in
the ascending limb, how men are more likely to recognize the risk, but like less likely to do anything about it.
Mhm.
Is there things like the EAAA plus or things more targeted on men that have been effective or anything, or is there anything like any strategies like about that?
For all the women in the room.
So they are working on a new iteration of EAAA for men, and part of that is response to some colleges that won't implement EAAA for women because of Title IX unless there's an equivalent for men. So they're currently working on that. There is a good program, and I've been involved in developing new content for the program that trains men to intervene when intoxicated. It's called Real Consent by Dr. Laura Salazar at Georgia State University. And it's a web-based program. I think it's about 4 hours, and that has actually shown to decrease men's perpetration and to increase bystander intervention. And so now we're trying to see, can men actually do that when intoxicated if we give them skills? So we're finishing up that study now, but basically men complete a new iteration where we integrated new alcohol content, training them what to do when intoxicated, and then they come into the lab with a virtual reality paradigm. They are either intoxicated or not, and then we're seeing what they do in a party situation where there's some risk. So we're really hopeful that that is going to help men actually be able to intervene when they're intoxicated. So if they can do it while sober and learn it while sober, hopefully they can be able to do it while they're intoxicated. So that work's being done. I know a couple other studies where people are trying to do this right now, but really in the last maybe 10 years is when we've even started to have evidence about how alcohol impacts bystanders, or have a better idea of what we can do in terms of encouraging men to intervene. But unfortunately, women are still most motivated.
Sounds like the EAAA platform is pretty time intensive, so 12 hours. Are there any thought of coming up with a briefer program that's still effective, that would maybe more accessible if it's not such a time commitment?
Yeah, there hasn't been any work done yet to try to decrease it. I think because it's really hard to figure out at this point, like what are the active components that we can actually take away while maintaining it being effective. But there is work to move it to an online format instead. And part of that really came out of wanting to have that program with transgender women, and that at campuses, there's not going to be enough women to deliver that program to. Nobody's going to invest in that. So if we could bring it to an online module where they are in Zoom and doing facilitation, that we can reach more people in specific populations. So I think that will really be a game changer in terms of getting this out to more people, such that universities don't have to invest all the resources themselves. In Canada, the Sexual Assault Resource Centers actually kind of pick up the program and then go out and deliver it to campuses. That hasn't been the model yet in the United States, but I think that is a great option if we can get funding and other people to invest at the community level to then deliver it across multiple campuses. There's development of programs for adolescents right now for EAAA, so there's a lot of adaptations happening right now.
Interesting. Sounds great.
Questions online? If not, maybe we'll wrap up. All right, well, thank you so much for that presentation, and thanks everyone online for joining us today. I think with that, we can officially close. So Shelby, if you're listening, you can officially close the Zoom. Thank you.
Thank you.